Hi everyone, my name is Cynthia Huynh and I am a physician assistant student at South University in West Palm Beach, and today I will be presenting my capstone project, which is implementing annual depression screening for adolescents at school. But before we get started, please click on this link to complete the pre-presentation survey. There's only 5 questions, so it should only take you a couple of seconds. Here's the presentation overview. So I'll be telling you a little bit about myself, the PA profession, discuss the learning objective, provide information on depression, show you an educational video, discuss depression in adolescents, depression screening using the PHQ-9. We'll do an interactive activity. I'll discuss depression treatment, the conclusion, and I'll have you fill out a post-presentation survey. So here's my capstone introduction. The goal of my capstone is to increase the number of adolescents aged 12 to 17 that receive treatment for depression by implementing annual PHQ-9 screening at school. My target audience is junior high and high school academic counselors, teachers, and school district administrators to implement the screening. My community partner is my school, which is South University. Disclaimer, the information provided in the presentation is for educational purposes only and does not substitute for professional medical advice. Please consult a medical professional or healthcare provider if you are seeking medical advice, diagnosis, or treatment. So next I'll tell you a little bit about myself. I was born and raised in the Bay Area in California. If you're not familiar, that is by San Francisco. I'm actually from San Jose, which is about 40 minutes from San Francisco, and I'm a first-generation Vietnamese American. I attended college at the University of California, Santa Cruz, which is a nice little beach town. And I graduated with a Bachelor's of Science degree in Molecular Cell and Developmental Biology in 2017. So after I graduated, I worked to obtain some patient care hours before I could apply to PA school. So I started working as a back office medical assistant at a cardiology clinic for 3 years. And during this time, I actually found my passion for working with the underserved Vietnamese community in San Jose. And I also did a lot of EKGs, helped set up for stress tests and Holter monitoring. And I applied to PA school, moved to Florida, and started PA school in January of 2021. And I am currently a second-year PA student on my clinical rotations, and I'm finishing up my 4th rotation in general surgery. So what is a physician assistant? Physician assistants, or now known as physician associates, are medical professionals who are licensed and board certified to examine patients, prescribe medication, order diagnostic tests and labs, develop and manage treatment plans for patients. PAs work in all areas of medicine and specialties such as primary care, family med, emergency med, and psychiatry. So this is some information I got from the 2022 AAPA salary survey. Here you can see that PAs practice in every work setting. Almost 60% of PAs practice in outpatient offices or clinics. About 38% of PAs practice in hospitals, 6% practice in urgent care centers, and PAs practice medicine in all specialties, about 28% in surgical subspecialties. We have almost 20% in primary care, and about 8% in emergency medicine. And here we have what patients say about PAs based on a survey. So 93% of patients say that PAs are trusted healthcare providers. 92% believe that having a PA makes it easier to get medical appointments, and about 91% say that PAs improve the quality of healthcare. What is Healthy People 2030? So the Healthy People Initiative actually began in 1979 when the Surgeon General Julius Richmond issued a landmark report titled Healthy People, the Surgeon General's Report on Health Promotion and Disease Prevention. Healthy People identifies public health priorities to help individuals, organizations, and communities across the U.S. improve health and well-being. Their vision is to build a society in which all people can achieve their full potential for health and well-being across the lifespan. Their mission is to promote, strengthen, and evaluate the nation's efforts to improve the health and well-being of all people. So for my capstone project, I had to pick a topic from the Healthy People 2030 topic list. What I chose was a topic in mental health and mental disorders, specifically to increase the proportion of adolescents with depression who get treatment. So at baseline, 41.4% of adolescents aged 12 to 17 with major depressive episodes received treatment in the past 12 months as reported in 2018. So the most recent data shows that 43.3% of these adolescents with the MDEs received treatment in the past 12 months in 2019. And their target goal is to have 46.4% of adolescents aged 12 to 17 with MDEs receive treatment. So what is clinical depression? Clinical depression is a mental health disorder characterized by persistently depressed mood or loss of interest in activities, causing significant impairment in daily life. Depression ranges in severity from mild, temporary episodes of sadness to more severe, persistent depression. Clinical depression is the more severe form of depression, also known as major depressive disorder, or MDD. How is MDD diagnosed? So to diagnose clinical depression, many providers use the symptom criteria for major depressive disorder in the Diagnostic and Statistical Manual of Mental Disorders, known as the DSM-5, published by the American Psychiatric Association. To be diagnosed with MDD, the symptoms must be present for at least 2 weeks and cause significant impairment in the patient's life. So what are the different types of depression? Major depression includes symptoms of depression most of the time for at least 2 weeks that typically interfere with one's ability to work, sleep, study, and eat. Persistent depressive disorder, also called dysthymia, often includes less severe symptoms of depression that last much longer, typically for at least 2 years. Perinatal depression occurs when a woman experiences major depression during pregnancy or after delivery, known as postpartum depression. Seasonal affective disorder, which comes and goes with the seasons, typically starts in the late fall and early winter and goes away during the spring and summer. Depression with symptoms of psychosis is a severe form of depression where a person experiences psychosis symptoms such as delusions, disturbing false fixed beliefs, or hallucinations, hearing or seeing things that others do not typically see or hear. What are the signs and symptoms of depression? So if you have been experiencing some of the following signs and symptoms most of the day, nearly every day for at least 2 weeks, you may be suffering from depression. Persistent, sad, anxious, or empty feeling or mood, feelings of hopelessness, feelings of irritability, frustration, feelings of guilt, worthlessness, loss of interest or pleasure in hobbies and activities, also known as anhedonia, decreased energy, fatigue, or feeling slowed down, difficulty concentrating, remembering, or making decisions, difficulty sleeping, early morning awakening or oversleeping, changes in appetite or unplanned weight changes, thoughts of death or suicide attempts, aches or pains, headaches, cramps, or digestive problems without a clear physical cause that do not ease even with treatment. So what are the risk factors? Depression is one of the most common mental health disorders in the US. Research suggests that genetic, biological, environmental, and psychological factors play a role in depression. Depression can happen at any age, and depression is now recognized as occurring in children and adolescents, although it sometimes presents more prominent irritability than low mood. So here we have the risk factors for depressive disorders in children and adolescents. So some biological factors include family history of depression, female sex, hormonal changes during puberty, low birth weight, maternal age younger than 18 years, medical illness, obesity, other psychological disorders like anxiety or learning disorders, and sleep disruptions. Psychological factors include emotional dependence, history of suicide attempts, ineffective coping skills, low self-esteem, negative body image, negative thinking styles, self-consciousness, and environmental factors include antisocial peer group, decreased physical activity, increased parental conflict, loss of relationship, such as death of a family member, low socioeconomic status, overeating, poor academic performance, poor peer relationships, substance abuse, and traumatic events, which include physical or sexual abuse. So next, I have an educational video to show you. It is called Living Through Depression, Julia's Story.
My name is Julia and I'm 19 years old. In 2017, was diagnosed with major depressive disorder. I almost lost this battle. I didn't think it was gonna get better, but it did. I've had anxiety since I was a little kid. I always had this feeling that something terrible was gonna happen, and that presented itself in tightness in my chest. I'd get really shaky. I would have a lot of stomach pain. Those were the physical ways that it came out. For the longest time, I didn't know that was my anxiety. I just knew that was something that happened to me. Around middle school, I started to get depressed, and it progressively got worse as I got into high school. Everything just seemed kind of gray. And a lot of worthlessness too. I don't have anything to offer. From the outside, I think I hid it pretty well. I was a straight A student. I hung out with my friends. I babysat all the time. I was involved in my church youth group. I didn't let people see that there was something going on. That was what stayed closed behind my bedroom door. Things started to feel more heavy. I started to self-harm as a way to cope. I started having suicidal ideation. I told my mom, I don't think I can keep myself safe. And I know my parents were shocked when they knew how bad it actually was. It was on a Sunday night. My mom called Children's, their hotline. I was evaluated by a social worker. And I think it was honestly the first time I was completely open about what was happening. And I told my social worker that I didn't necessarily want to die. And I knew that I needed a break from what was happening, from all the things I was feeling, and death seemed like the only option. And I just remember crying to her and being like, I don't know what else to do. Like, I'm stuck. Here I was, completely broken. I could barely see the point in staying alive. I felt so ashamed of myself. And these people, they just treated me like a person. I felt validated and I had some hope. And I knew that okay, when I ask for help, help is given and it works. And I knew that this break I was looking for could be found in a hospital room instead of dying. Today, I am in remission from my depression for the first time in who knows how long. I'm getting to know parts of me that aren't just anxious and depressed Julia. I'm clean from self-harm. I'm majoring in social work, and I really want to work in behavioral health with children, specifically in a crisis or inpatient setting. I've started to become really passionate about advocating once I made it to the other side, because I almost didn't make it. You're not at fault for where you are right now. It's okay to be afraid, but I don't want you to give up. Because the thing about depression is it lies. You know, you gotta fight to be here because it does get better. And all of these lies will eventually go away. You just have to hold on because it doesn't get to win. It doesn't get to take you. Because you're stronger than that and you're worth more than that, and it's possible.
So next we'll discuss the prevalence of major depressive episode among adolescents. This graph here shows that the past year prevalence of major depressive episodes among US adolescents in 2020, there's an estimated 4.1 million adolescents aged 12 to 17 in the US that had at least one major depressive episode. This number represented 17% of the US population aged 12 to 17. The prevalence of major depressive episode was higher among adolescent females when compared to males at 9.2%. The prevalence of a major depressive episode was highest among adolescents reporting 2 or more races at 29.9%. Major depressive episodes with impairment among adolescents. In 2020, an estimated 2.9 million adolescents aged 12 to 17 in the US had at least one major depressive episode with severe impairment in the past year. This number represented 12% of the US population aged 12 to 17. Treatment of major depressive episodes among adolescents. In 2020, an estimated 41.6% of US adolescents with a major depressive episode received treatment in the past year. Among adolescents with major depressive episodes with severe impairment, an estimated 46.9% received treatment in the past year. Why aren't more adolescents with depression receiving treatment? As we saw from the last slide, for both groups, less than 50% of adolescents with major depressive episodes receive treatment. So based on a journal article I found, it states that adolescent major depressive disorders prevalence has nearly doubled in the past decade. The U.S. Preventative Services Task Force endorses universal adolescent MDD screening in primary care. However, most adolescents lack preventative health care, resulting in worsening disparities in MDD screening and treatment. So how can we increase the proportion of adolescents with MDD who receive treatment? Screening is key. Most adolescents lack preventative health care, which means they aren't having annual exams and getting depression screening by their primary care provider. This can be due to different factors such as lack of health insurance, barriers to access health care, or having parents who aren't health literate. If adolescents aren't getting screened, they will not get properly diagnosed or receive treatment for depression. How can we increase depression screening for adolescents? So once again, the objective of my capstone project was to increase the number of adolescents aged 12 to 17 that receive treatment for depression by implementing an annual PHQ-9 screening at school. Students can be screened for depression by their academic advisor or counselor at school using the PHQ-9. Students that score greater than 10 for the PHQ-9 should be referred to a mental health counselor or therapist at school if possible to maintain confidentiality. If this option is not available, students should be advised to see their primary care provider for further evaluation and treatment if necessary. So what is the PHQ-9? The PHQ-9 objectifies and assesses degree of depression severity via a questionnaire. The PHQ-9 is a multi-purpose instrument used for screening, diagnosing, monitoring, and measuring the severity of depression. So for the interpretation of PHQ-9 scores, total scores of 5, 10, 15, and 20 represent cutoff points for mild, moderate, moderately severe, and severe depression, respectively. Note, so question 9 is a single screening question on suicide risk. A patient who answers yes to question 9 needs further assessment for suicide risk by an individual who is competent to assess for this risk. Next, we have our interactive activity. So we will practice screening for depression using the PHQ-9. We'll just click on the link here, which should open up a web browser. So this is MD Calc. PHQ-9 questions are listed here. So you can practice using the PHQ-9 on a friend or family member, or you can just follow along here. Ask the patient how often have they been bothered by the following over the past 2 weeks. First question is little interest or pleasure in doing things, and the answer choices are as follows: not at all, several days, more than half the days, and nearly every day. And the responses have corresponding points. So here we have 0, 1, 2, and 3. And these responses will be the same for all 9 questions. And as you ask the questions and click on the appropriate responses, the total score will populate here at the bottom. Right, so we'll just practice answering the questions here. Feeling down, depressed, or hopeless, trouble falling or staying asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you are a failure or have let yourself or your family down, trouble concentrating on things such as reading the newspaper or watching television, moving so slowly or speaking so slowly that other people notice, or being fidgety and restless, thoughts that you would be better off dead, or thoughts of hurting yourself in some way. So next you ask the patient, how difficult have these problems made it to do work, take care of things at home, or get along with other people? All right, so after we have selected the responses, the total score here says 11 points. So scores ranging from 10 to 14 suggest moderate depression severity. Patients should have a treatment plan ranging from counseling, follow-up, and or pharmacotherapy. So as you can see from the example here, the PHQ-9 is a very simple assessment. It takes less than 2 minutes to complete this questionnaire. right. And here is a breakdown of the PHQ-9 score interpretation. So a PHQ-9 score of 0 to 4 suggests that there is none to minimal depression severity. Proposed treatment actions, none. A score of 5 to 9 suggests mild depression severity, with proposed treatment of watchful waiting and repeat PHQ-9 screening at follow-up. A score of 10 to 14 suggests moderate depression severity, with a proposed treatment of coming up with a treatment plan, consider counseling, follow-up, or pharmacotherapy. A score of 15 to 19 suggests moderately severe depression. Proposed treatment is active treatment with pharmacotherapy and/or psychotherapy. And lastly, we have a score of 20 to 27 indicating severe depression. Proposed treatment action includes immediate initiation of pharmacotherapy and, if severe impairment or poor response to therapy, expedited referral to a mental health specialist for psychotherapy and/or collaborative management. So you're probably wondering, how accurate is the PHQ-9? The PHQ-9 is a well-established, validated screening tool. A score greater than 10 has a sensitivity of 89.5% with a specificity of 77.5% and a positive predictive value of 15.2% for the diagnosis of MDD among adolescents. Why should we implement annual PHQ-9 screening for adolescents at school? In a large statewide randomized control trial of schools with diverse student body, universal school-based depression screening successfully doubled student initiation of MDD treatments and services. Major depressive disorder is associated with significant morbidity and mortality in adolescents. Suicide is one of the leading causes of death between 15 and 19 years. Both AAP and USPSTF recommend routine depression screening of adolescents. Next, we'll discuss the treatment for major depressive disorder. Treatment of adolescent depression consists of psychotherapy, pharmacotherapy, or a combination of these. The American Psychiatric Association and American Academy of Child and Adolescent Psychiatry recommend that psychotherapy always be a component of treatment for childhood and adolescent depression. They recommend psychotherapy as an acceptable treatment option for patients with milder depression and a combination of medication and psychotherapy in those with moderate to severe depression. Treatment should correspond to the level of depression, patient preferences, the developmental level of the patient, associated risk factors, and availability of services. Cognitive behavioral therapy, or CBT, and interpersonal therapy have been proven effective in the treatment of adolescent depression. CBT usually consists of behavioral activation techniques and methods to increase coping skills, improve communication skills and peer relationships, solve problems, combat negative thinking patterns, and regulate emotions. In contrast, interpersonal therapy generally focuses on adapting to changes in relationships, transitioning personal roles, and forming interpersonal relationships. A combination of CBT and medication has been shown to be more effective than medication alone in attaining remission of depression. Consensus guidelines recommend fluoxetine or Prozac, citalopram, and sertraline or Zoloft as first-line treatments for moderate to severe depression in children and adolescents. Treatment should begin at the lowest dosage available and titrated according to the patient's response to adverse effects. All antidepressants have a black box warning for an increased risk of suicide. Therefore, close monitoring is recommended, such as weekly telephone calls, scheduled visits for the first month of therapy to assess for suicidality and other adverse effects. So conclusion. To wrap up the presentation, once again, the goal of my capstone was to increase the number of adolescents aged 12 to 17 that receive treatment for depression by implementing annual PHQ-9 screening at school. My learning objective was to have the audience understand the benefit of screening for depression in adolescents and implement depression screening as part of academic counseling meetings with students by the end of this presentation. So this wraps up my capstone presentation. Thank you again for your time and participation. But before you go, please complete this post-presentation survey. Once again, it's only 5 questions and it'll only take you a couple seconds. Thank you so much again for your time, and I hope you learned something from my presentation today. And here are my references.